All right, welcome back. We're going to continue the OB series with discussing late pregnancy complications. TORCH, or TORCH syndrome, which is a bit of a misnomer. TORCH itself is an acronym that stands for toxoplasmosis, other agents, rubella, cytomegalovirus, and herpes simplex, which are all infections that can pass from mom to fetus, either during pregnancy or during the childbirthing process. Symptoms include things like fever, lethargy, cataracts, jaundice, hearing loss, low birth weight, microcephaly, all sorts of complications that can exist with these infectious processes, both to mom but predominantly to fetus. Toxoplasmosis is caused from handling or eating food that are contaminated or handling cat litter. Particularly early in pregnancy, there's a lower chance of passing it on to the fetus, but as pregnancy develops and time goes on, that risk increases significantly. Cytomegalovirus is a member of the herpes virus family. It can remain dormant in the body for years, and pregnant women have an increased risk for an active infection and more serious complications. Newborns with CMV are susceptible to things like liver problems, swollen glands, rashes, poor weight gain, lung problems, and blood problems as well. As far as pathophysiology as related to bleeding during pregnancy, abortion is the expulsion of the fetus before the 20-week of gestation. They're classified in two ways. You have spontaneous abortion, which is commonly referred to as miscarriage, and then an elective abortion, which is an intentional abortion process. The abortions are further broken down into several types, including habitual abortions, which are 3 or more consecutive miscarriages, and these causes can include things like ovarian issues, uterine malformations, cervical conditions, and infections. If an abortion is not yet happened, but there's a significant potential, we call that a threatened abortion. And this is when an abortion is attempting to take place. It typically occurs within the first 20 weeks of gestation, and it's characterized by vaginal bleeding during that first half of pregnancy. It can progress or it may subside, and predominantly for us in the pre-hospital world is to provide transport and ultimately supportive care. An imminent abortion is a spontaneous abortion that cannot be prevented. Signs and symptoms include severe abdominal pain, vaginal bleeding, cervical dilation. Prehospital care includes, amongst being emotionally supportive, blood pressure maintenance, and the concern for hypovolemia. So when you encounter these in the pre-hospital world, it's important to wear two hats, if you will. One is going to be to provide emotional support, as these are often very traumatic events for both mom and family. So make sure that you are in an appropriate manner interacting with these patients and providing emotional support. Also monitoring carefully for complications, things like hypotension, shock, and hypovolemia. Treatment includes establishing an IV line of normal saline, administering 100% O2, particularly if the patient is hypoxic. You should place ECG monitoring on the patient if it's within your certification level and you have the capabilities, and then provide emotional support with rapid transport, again, while monitoring signs for shock. Another important thing to understand about abortion is the birthing process, particularly if they are later in pregnancy, is just the same as it would be for a term pregnancy. The difference being that often the fetus isn't viable, and that's why we term it abortion. So the maternal changes that are going to occur during the abortion process are the same as if mom was engaging in childbirth, which creates further complications, emotional and otherwise. And so I encourage you to be respectful and humane during this process. An incomplete abortion is where part of the products of conception remain in the uterus. This is an indication of this can be continuous vaginal bleeding even after expulsion of the fetal material. Watch for signs and symptoms, again, of shock, and consult medical control and start an IV line and be prepared to administer saline boluses for blood pressure support if your certification allows. A missed abortion is where the fetus dies during the first 20 weeks of pregnancy, but remains in utero. On examination, the uterus can feel hard, a hard mass. The fetal heartbeat can't be auscultated or can't be heard or seen on ultrasound. A septic abortion is when the uterus becomes infected following an abortion. History includes fever and bad-smelling vaginal discharge after the abortion. Physical exam will reveal a fever and abdominal tenderness. Patient treatment for this is the same: oxygenation, blood pressure support, transportation, and ECG monitoring. Third trimester bleeding is during the third trimester, the gravid patient is at the greatest risk for hemorrhage, or hemorrhage indicates the most significant complication. There's a large volume of blood present, and if you'll remember from our previous discussions that the gravid patient builds up an excess of blood supply during pregnancy for preparation for childbirth, but this additional blood volume also creates a risk factor for her as well, because the compensatory mechanisms that are in place aren't quite as functional as they are in the non-gravid patient. The ectopic pregnancy is when the ovum implants somewhere besides the uterus. The patient will usually present with severe abdominal pain and hypovolemic shock. Ectopic pregnancy should be considered for all female patients of childbearing age with severe low abdominal pain. Abruptio placenta. This is a premature separation of the placenta from the uterine wall. The patient will report a sudden onset of severe abdominal pain. It's not uncommon for the patient to describe that they don't feel baby moving. And vaginal bleeding can occur and is typically hallmarked with a dark red blood color. Physical exam can reveal signs of shock, a tender abdomen, and a rigid uterus, and fetal heart sounds may be absent. Placenta previa is when the placenta is implanted low in the uterus and obscures the cervical canal. Chief complaint for this is usually vaginal bleeding that's painless and hallmarked by bright red blood. The uterus is soft and non-tender, but as you can see, this is going to pose a complication during childbirth. When you're assessing bleeding during pregnancy, try to determine the nature of hemorrhage. You can use acronyms like OP, QRST to help elaborate on chief complaint and identify changes in things like orthostatic vital signs. You also can take a look and assess for things like Gray Turner's or Cullen sign, the periumbilical bruising or flank bruising, which may indicate blood pooling or excessive internal hemorrhage in various areas of the perineum. For management of hemorrhage during pregnancy, during late pregnancy, keep the gravid patient on their left side. Administer oxygen to support for hypoxia, rapid transport. If your certification level allows, you can start an IV line and consider normal saline and providing fluid boluses to support circulatory status as needed. Obtain ECGs and baseline vitals, and then for vaginal hemorrhage, loosely place trauma pads over the vagina. Nothing should enter the vaginal canal.